This is a 5-minute medicine series on atrial fibrillation. Atrial fibrillation is a chaotic and diffuse pattern of electrical activity in the atria with deterioration of mechanical function. The ECG pattern of AFib shows absence of discernible P waves, which are replaced by fibrillatory waves that vary in amplitude, shape, and timing. The ventricular response is grossly irregular and often rapid, except when there is concomitant AV block. 2 or more episodes is considered recurrent. Once it has been deemed to be recurrent, it can be classified as paroxysmal, persistent, or permanent. Paroxysmal means it is self-terminating, usually in less than 7 days. Persistent atrial fibrillation can refer to the first episode of AFib or the culmination of recurrent paroxysmal episodes. When cardioversion fails or is not attempted, AFib becomes permanent. Atrial fibrillation is the most common clinically significant arrhythmia, accounting for most hospitalizations due to rhythm disturbances. Prevalence increases with age. For instance, it occurs in less than 1% of those between ages 60 and 65, but in 8 to 10% of those older than age 80. Atrial fibrillation may be incited by any of ischemic injury, valvular disease, hyperthyroidism, electrolyte imbalances, hypertension, postoperative stress, pericarditis, stress from a pulmonary embolism, or dehydration. AFib may occur alone or in combination with structural heart disease or obvious etiologic factors such as hyperthyroidism or undiagnosed hypertension. Patients may present with palpitations, chest discomfort, dyspnea, lightheadedness, syncope, or have symptoms of a TIA or stroke. The minimal initial evaluation should include an ECG to confirm the rhythm, chest X-ray to rule out pulmonary edema, transthoracic echocardiogram to look for predisposing factors like valvular disease or complications of AFib like an atrial thrombus, CK, troponin, a TSH level, and electrolytes, including extended ones, which can all help with potential etiologies for AFib. If the atrial fibrillation is new or uncontrolled, telemetry should be ordered as well to determine if you have achieved adequate control. In the acute management of atrial fibrillation, you need to make a couple of considerations. When the ventricular response is fast, you can achieve rate control with beta blockers or calcium channel blockers, both of which have similar efficacy in the acute setting. When the patient's symptoms have been present for greater than 48 hours or the duration is uncertain, anticoagulation is needed to reduce the risk of stroke. When the patient is hemodynamically unstable, cardioversion is indicated. Cardioversion can be done in 2 different ways. Electrical cardioversion is performed in the fasting state and requires anesthesia. Pharmacologic cardioversion can be considered if anesthesia is best avoided. A class 3 antiarrhythmic like amiodarone can be used, but should be done under cardiac monitoring because of the risk of inducing a ventricular arrhythmia. Prior to cardioversion, you need to consider the duration of symptoms. If present for more than 48 hours or the duration is uncertain, you need to anticoagulate with warfarin for 3 weeks or obtain a TEE to rule out a left atrial thrombus prior to cardioversion. This is done because if a left atrial thrombus is present, cardioversion may induce a stroke via emboli from the thrombus. Both approaches also require full anticoagulation for 4 weeks following cardioversion, as cardioversion can cause some stunning of the myocardium, which may predispose to clot formation. In the long-term management of atrial fibrillation, either rate or rhythm control strategies can be used. Rate control can be achieved by beta blockers or non-DHP calcium channel blockers like verapamil or diltiazem. Digoxin can help enhance these drugs and is useful in patients who are becoming hypotensive. A controlled heart rate is one that is less than 110 while resting, as the Race 2 trial demonstrated outcomes are similar as with tighter controls. Be careful using multiple classes of drugs together, as this puts patients at high risk of AV block. Rhythm control should be used in symptomatic patients to help improve the likelihood of remaining in normal sinus rhythm. Examples include amiodarone or sotalol as rhythm control agents. The AFFIRM trial demonstrated that rate control and rhythm control have similar results in the reduction of symptoms, mortality, and stroke risk. Further, the rhythm control arm had more hospitalizations and adverse drug reactions. This is the basis for current recommendation that rhythm control be used in patients who are symptomatic and do not tolerate the rhythm well, whereas rate control is reasonable in patients with minimal symptoms. The risk of stroke in persons with non-valvular atrial fibrillation is 2 to 7 times the rate for persons without atrial fibrillation. A meta-analysis of several randomized studies has shown that adjusted dose anticoagulation with warfarin is effective in preventing strokes. A risk reduction of just over 60% compared with placebo was reported. Patients with valvular atrial fibrillation were not included in this meta-analysis, as it is known this group is at high risk for stroke and should always be treated with full anticoagulation. The target intensity for anticoagulation is an INR between 2 and 3, a range that provides the best balance between efficacy and bleeding risk. The CHADS-2 risk stratification scheme considers risk factors for stroke in patients with atrial fibrillation and helps guide the agent to use for antithrombotic therapy. The CHADS acronym is derived from the individual stroke risk factors: congestive heart failure, hypertension, age, diabetes, and prior stroke or TIA. Patients with prior stroke or TIA are assigned 2 points and given 1 point for each of the other risk factors. Those with an overall score of 0 or 1 are considered low risk, and using aspirin alone is considered sufficient for antithrombotic therapy. People with a score of 3 or higher are considered high risk and should be on oral anticoagulation with a target INR between 2 and 3. Those with a score of 2 are intermediate risk, and the risks and benefits of warfarin should be considered on a case-by-case basis, including consideration of comorbidities and risk of hemorrhage. Atrial fibrillation can cause patients to become unstable. Call a senior medical resident if you notice hypotension, chest pain, dyspnea, or an altered level of consciousness. In summary, atrial fibrillation is a common arrhythmia. Acute management focuses around rate control with beta blockers or calcium channel blockers. Cardioversion may be necessary for unstable or hypotensive patients, and call for help in making a decision of pharmacologic versus electrical cardioversion. In chronic atrial fibrillation patients, the AFFIRM trial has changed practice such that the rate control is always a first-line strategy, and there are less complications than compared to the rhythm control strategy. CHADS 2 score should be used to determine anticoagulation strategy of aspirin or Coumadin in patients for which there are no contraindications for anticoagulation.